Thanks for the introduction. Good afternoon, respected member of the council and fellow physicians. I am Dr. Đỗ Đăng Tân from Bạch Mai Hospital. And I am honored to be here today to present our research about the efficacy of the anti-selective Ths in the treatment of early ACC compared to radio frequency ablation. As we all know, ACC remains one of the most prevalent and challenging malignancies worldwide, particularly in the region with high rates of chronic hepatitis. And I will show you a very popular guideline, the BCLC guideline version 2022, according to which the primary treatment of the early stage ACC is ablation and resection, but surgery is not suitable for some patients with the impaired liver function, the patient with underlying medical conditions that prevent surgery, or some patients refuse the surgery, while RFA is a curative treatment. However, in certain situations, we can miss some problem, such as the difficult visualization on ultrasound, or some high-risk location or high-risk recurrence. And TACE can be chosen in this situation as an alternative method. So we move to the anti-selectivity CTA concept. The definition of the CTA is the CTA at the most distant portion of the subsegment hepatic artery. You can see the schematic. If the microcatheter is here, the pharynx of the arterial blood feeding tumor, it can allow to injection a large volume of iodized oil into the tumor and the portal veins surrounding the tumor, and it leads to complete necrosis of the tumor and the parenchyma surrounding the tumor, including some daughter nodule, and this affects likely the ablation. And according to the author Shiro Miyama from Japan, the anti-selective CTA can replace surgical resection and IRA in some patients. Another rich study, they compare the efficacy of the anti-selective CTA with the surgery, and they found that there is no difference about the overall survival. And in the Bạch Mai Hospital, we almost the patient in the Bạch Mai Hospital receive the treatment decision from multidisciplinary tumor board, and here the patient with early stage ACC who cannot undergo surgery. First, we choose the RFA as the first choice, and if there are any difficult or challenging, we train to anti-selective CTA. And the question is the anti-selective CTA have whether have the efficacy and recurrent rates comparable to the RFA. And this is also my objective of my research. And I show you the research diagram. The time from January 2021 to January 2024. And the patient will choose either diagnostic ACC at early stage with the child A, PS 0 to 1. The patient who cannot undergo the surgery, and the patient will be treated with RFA and anti-selective CTA. And after 1 month, we assess the tumor with the embraces criteria, and if the complete response is not met, we addition the treatment. And if the patient have a complete response, we follow up the patient at least 3 months. And the end point of the study, we focus on the local tumor progression rate the intrahepatic distant recurrent rate, and the durable local complete response time, the disease-free survival time. And here is the intervention procedure. First, the patient we assess on the MRI or CT scanner. Then we do angiography to detect the feeding tumor artery, and the ultraselective will perform. Then we injection lepiodon with the chemo, and until the portal vein is visualization, we occlude the artery, assess at 1 month, and follow up the patient. And my result of the research, we have about 30 patients with 35 nodules treated with ultraselective CT, and about 63 patients with 17 nodules with IBA. The table shows the baseline characteristic of the patient in two groups, and we can see there are no significant difference about the characteristics of the two groups. And after follow-up time, I found that the average follow-up time between two groups, so no significant difference, about 20 months at the ultraselective CT group, and 22 months at IBA groups. And about the complete response rate at 1 month, the local tumor progression rate, the intrahead distant recurrent rate of the two groups, still I found that there's no significant difference. And my research is quite similar some other author like Miyama and the Zitun. And here I show you a chart about the durable local complete response time and disease-free survival time. We see that on the ultra-CT group is quite higher and the IBA, but there are no significant difference. And I show you a case from my research. A 62-year-old male patient with newly diagnosed of SCC. And on CT scanner and the MRI, we can see a nodule at the segment 8 adjacent to the diaphragm with clear boundaries, and the diameter is about 3 centimeters. And the patient was not indicated the surgery because of impaired liver function. And we try to have a artificial pleural. And after the CT scanner, we found that it missed target, and we trained to ultraselective CT with portal vein visualization grade 1. The CT scanner after treatment, at the time of 20 months after treatment, the patient still complete the response and continue to be followed up. And in conclusion, my study about two groups with baseline characteristic and follow-up, no definitive sequence, and the outcome about the tumor response rate, local tumor progression rate, durable local complex time, and the intrahepatic distant recurrence rate is so no significant difference. And I can conclude that the effectiveness and recurrent rates of ultraselective CT are comparable to those of IBA in the treatment of early SCC. Thank you for your attention.
Okay, thank you. And I have one question for you, because in the criteria for selection, between the two group, and because in early stage, is unsuitable for the surgery, and maybe the patient refused for treatment of surgery. So we select for the IFA or ultraselective taste. But in case of IFA, if the patient have a high risk of recurrence, you move to the ultraselective taste. So this any effect for the result of the treatment?
Any effect? You mean
It means that in case of high risk of recurrent,
yep.
So it means that the effect is not good for this group.
I think
it's not homogeneous for between the two groups.
Yeah, okay. In those group who treat with the IFA by my hospital, if the patient we treat in our center, the radiology center, almost patient have a high risk location, and I think it maybe affect the results of IFA group, but it can be improvement the outcome by use ultra-selective CT. Yep.
Because in the reason so that for the group of the ultra-selective, the follow-up with the recurrent is higher than in the IFA. It means that prognosis is different between the two groups.
The recurrent rates of the ultra-selective
local tumor progression rate,
like
you see on the ultra-selective, because it's not homogeneous in the two groups.
The baseline characteristic of the two group, I don't demand about the location. Yeah, I think we can care about the tumor diameter and the other characteristic of the tumor. And if the high risk location or high risk recurrence of IFA, we should find another method to alternatives.